Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher, and today is episode 74. It's the last Tuesday of the month, so you're going to get my top 10 Tuesday today, but I'm going to change it up a bit. It's not going to be the top 10 coding questions for the month of March. I'm going to bring you the top 10 coders' pet peeves, and I will try not to get petty, but we may have a little bit of pettiness in there. I've got some good ones that I've received through email and just through texting and through my social media accounts. And I just thought this was an important topic to see what we can do with it. And hopefully I can help you through the process, because I know as much as you love your job as a coder, a biller, a healthcare professional, an office manager, anybody that's in the healthcare industry, in the administration department, or even, back office, anybody. I know you've got some pet peeves and some issues. So we're going to focus today on what the coders go through. I'm sure the billers are going to be part of this conversation. And so hopefully you'll appreciate some of the comments that I've received. But first, the Codecast podcast is also brought to you by Orion Health, revolutionizing global healthcare so every individual receives the perfect care for them. Join the revolution, orionhealth.com. So just to reiterate what a pet peeve is, these are minor annoyances that can cause some major irritation, I would say. Pet peeves aren't just about complaining, though. They're the out-of-the-box form of communication, actually. And if addressed correctly, they provide an opportunity to improve productivity, employee satisfaction, and, really just make for a less hostile work environment. So rather than treat pet peeves as irritants that we cannot address, we should think of them as problems that maybe can be solved, just kind of like the old adage, making lemonade out of lemons. So here's my top 10 list of a coder's pet peeves. So number 1 would have to be unclear or illegible clinical documentation. Medical coders want to select the correct diagnosis code properly linked to treatment procedures and services. So we do not like to abstract the coding information from a checklist of symptoms or a super bill or a fee ticket or it's a charge master without details to describe the treatment given. Most of us know the medical coder's mantra, not documented, not done. Mine is, if I can't win an appeal, if ever denied, I'm not reporting it. And that's the first thing I look at. Physicians and providers must complete clear, concise, and detailed documentation and in each medical setting. Then sign, authenticate the record in a timely manner. Timely manner is another one. And then clinical details, such as the trimester, or I should say which trimester of a pregnant patient, what is relevant. So, we also see catheter placements or laterality, right or left side of the body, or injected versus visualized, open versus laparoscopic or arthroscopic. One of my favorite ones in GI, polypectomy, or should it say removed polyp in the sigmoid colon by snare. So coders are only as good as what we get. We cannot assumptive code. Think about it like this. We cannot assume facts not in evidence. So I know that sounds like a Law and Order episode, but it's really what it is. I'm looking at ICD-10 codes for specificity, for example. You need to know stages of categories, such as stages of chronic kidney disease or fracture types, or types of atrial fibrillation or tachycardia. Think about those fracture types. Sometimes I just get arm fracture, seriously, and it would be, is it open or closed, displaced or non-displaced? Let's say you just said radial fracture, right or left joint. Where's the laterality? Upper shaft, lower joint. Seriously, is it delayed healing? Is it current? Is it sequela? Is it the initial encounter? There's so many details that we need, and that clinical documentation, when it's lacking, it's really a pet peeve of ours. So please make sure you have that information. Number 2, and I got this one from several people, the physician does not respond to a query in a timely manner. When this happens, the code cannot be coded, which delays reimbursement, and medical coders can be held to fault if their productivity is low because providers aren't responding to queries. So one of the things that I'm excited about, I've been invited back to AAPC Hawaii, my 14th year as a conference speaker, and my presentation is going to be the art of the physician query. I also did a podcast on this, episode 33, if you go back to June and take a look. But you'd really need to go to your physicians and say, hey, we need to have this responded to in a timely manner. I'm not just sending you an email so you can, at the end of the week, let me know what's going on. As you know, there's some timely issues when it comes to filing. So definitely a pet peeve of not getting what you need from the physician. Missing a diagnosis that requires a code first or use an additional or underlying code. That's our third pet peeve. This can happen when a coder relies completely on computerized assistant coding, or CAC for the encoder system. Most computerized assistant systems do not tell the coder which diagnosis is needed for an additional or underlying diagnosis code. So that one missing detail, that can affect reimbursement, can affect your HCCs. In these instances, the coder should use their current ICD-10 CM manual. Coding resources such as reference guides work well when they're continually coding for the same assigned medical specialty. I get a lot of questions about, Terry, do you have cheat sheets? Please do not ever call them a cheat sheet, at least not in my presence. A cheat sheet begs the question, who are you trying to cheat? I'm an expert witness and I give expert testimony to a lot of cases that deal with both the physician and the payer side. And the first thing the attorney asks is, well, do you recommend cheat sheets? And I am clear, no. And they say, well, don't you create them? No. Well, we have here a cheat sheet for some. I said, no, look at the top. That's a reference guide. I do not create cheat sheets. We're not trying to cheat anybody. They're reference guides so that for routine services, they have a quick access. That I would never, ever call anything a cheat sheet. So please take that out of your healthcare professional vocabulary. Number 4, the provider elects or selects an unlisted CPT code when documentation supports a more specific code. This also works vice versa, where I get a specific code and I'm like, that's not the code. You're trying to get close because you want to be paid, but the CPT book says you need to go to unlisted if the code isn't exactly what you're doing. And this could lead to payment unbundling, potential compliance violations, and be careful because, and I actually ran across this in one of my Coding Corner clients this week, that an unlisted code is really for an entire encounter. It's not really it's not really to be used when you have multiple surgical codes because it automatically gets denied, because there's no value to it. So an unlisted code means at this encounter, this one procedure, this is a big procedure, or it was so inclusive of different things that there was no single code for, this is what I'm coding. The problem I see is sometimes that unlisted code is used with other codes that are valid and do get paid, and it becomes a problem for the entire claim. So that's actually a pretty big number 4 pet peeve, is just make sure that you don't either use an unlisted code when there's actually a code, or when there isn't a code, you need to go and default to an unlisted. Number 5 is too many diagnoses. If more than 25 diagnosis codes are assigned for the inpatient record, or if more than 12 diagnosis codes for the outpatient for the CMS 1500 claims form, the coder must remove diagnosis codes to transmit the claim because there's too many. So the medical coder must ensure that the diagnoses are in correct sequence, plus follow standards with national coding conventions. And so, you have to use the coding clinic. You're making a lot of judgment calls there. So you want the most important of the day, and then any kind of, or I should say any secondary diagnoses that contribute to that day's encounter that either were addressed or going to contribute to the medical decision-making process. But too many diagnoses, we want as many as we can handle that we're addressing today, but just try not to get carried away there. So to recap our first 5, number 1, unclear or illegible clinical documentation. Number 2, the physician does not respond to a query in a timely manner. Number 3, missing a diagnosis that requires a code first or use an additional code or underlying code. And number 4, the provider elects an unlisted code when documentation supports a more specific code or vice versa. And then number 5, too many diagnoses. So before we get to the rest, we're going to take a minute to talk about our coding question. So today, I actually had a coding question regarding physician supervision of diagnostic tests. So somebody had said, so Terry, I know that there are 1, 2, and 3 there are indicators that are put on codes in the physician fee schedule for Medicare. And basically it determines if the supervision is general, direct, or personal. But what is 4, 5, and 6? I'm seeing these other indicators. Okay, so as the coder said, or as the question stated, procedures that are performed under general supervision are 1, direct supervision of a physician is 2, and personal is 3. 4, this says that the physician supervision policy does not apply when the procedure personally furnished by a qualified independent psychologist or clinical psychologist, so otherwise must be performed under the general supervision of a physician. Number 5, physician supervision policy does not apply when procedure personally furnished by a qualified audiologist, otherwise must be performed under general supervision of a physician. And then number 6, procedure must be personally performed by a physician or a physical therapist who is certified by the American Board of Physical Therapy Specialties as a qualified electrophysiological clinical specialist and is permitted to provide the service under the state law. So everyone always says there's 3 levels of supervision. Actually, there are 6 indicators for supervision. So those are some things that can just be helpful for you as you're looking through some compliance issues. Today's coding question was brought to you by WASOCAL, Women in Healthcare Administration of Southern California, a nonprofit organization for women healthcare leaders, whasocal.org. So now we're at the back end. So number 6 of our pet peeves for the coders, lackluster support. So coding requires concentration, and coders who are assigned multiple tasks, answering the phone, processing insurance denials, verifying insurance, and posting payments, will struggle to manage stress and do their job productively. But I noticed that a lot of practices now are multitasking employees. And so what I would recommend, especially if you're understaffed or you are an employee that's to take on more than just coding, have specified days for certain tasks and make sure that you focus on that. I know that it can be very appealing, or I should say very, what's the word I'm looking for? It can draw you in to look at that stack of, every time you walk into your office, that just stack of problems sitting on your desk that you need to get to. But if you are also a collector and a biller and a coder, you need to find certain days where you focus on one task, that you're catching up all your coding, that you're just working on your denials, that you're just looking at AR work. Otherwise, you're basically not going to be able to be productive on any of your tasks. So try to do that. But that is definitely one of the biggest pet peeves, is there's just not a lot of support to be able to get full work done. Number 7, no compensation or time off for ongoing education. So coding accuracy is crucial to reimbursement and compliance, and it is up to the organization and really to your financial advantage. And it is encouraged that coders stay up on and up to date with frequent coding and compliance guidelines. You really want to, not just listen. I appreciate you listening to the podcast and why they allow us to do it for free right now. I should say you listening to it for free. It's not free for me. It costs money to put it on. But why you can listen to it at no cost, definitely enjoy it. I think at some point they're going to start charging for them. But if you can't get to a live seminar or a conference, really check out considering a webinar. Take a look at my website. We just posted the second quarter. It's $199 for a 60-minute webcast. You get CEUs. You also get a PDF of the material that you get to keep to reference later. And so something to consider, but it's something that you can do in your office and share with people. So something just to keep in mind if you can't get to a live, education piece. But the other thing is outdated coding books. That falls under this, ongoing education. I can't tell you how many times I will present a live course and I'll have somebody there with 2 to 3-year-old books, and they're trying to ask questions where if they had the new book, the question would be answered for them. So for those administrators or physicians or anybody listening in that feels that, coding education is not important, it's your bread and butter. You need to make sure that your coders are updated and educated, and that you're taking certain classes that you have to pay for. Not everything is free, so really try for that. Number 8, unfair criticism for using reference guides. See what I did there? No cheat sheet. Or for codes or insurance rules. So using so-called reference guides are much better solution than relying on memory only, especially if you have some complicated specialties that you're dealing with, or if you're new to coding. The CPT and ICD-10 manuals are necessary resources, but for coders who are used to seeing many of the same types of claims on more of a routine basis, a more concise and targeted coding resource can be a big productivity advantage. So not having that is a definite pet peeve. Number 9. Now this one, okay, we're going to get a little petty. So I told you there was going to be some pettiness in there. Office noise, office drama, let's face it. Concentration can be difficult to an active office, but medical coders can wear headphones to help block out the noise. But sometimes certain music or podcasts, not mine, of course, also may distract the coders. So you need to have at least a relatively quiet office. But if a certain person or coder is also used to having some background noise when they work, allow them to use their headphones as long as you don't see their productivity decrease. Another thing I would recommend too, along with this, is try to offer your coders that you feel that have really earned the right and the respect to be independent, maybe one day a week where they can work remotely. So it's hard to work remotely on Mondays. Let's face it, Mondays are tough because the physicians who've been on call are throwing stuff on your desk. Patients haven't been able to get in to see the physician. And so it's a very busy phone day. So Mondays are tough to give people that day to work remotely. Unless you have somebody who's just really grumpy on Mondays, then you might want to tell them, okay, Tuesday's your Monday. But this can really, add to your productivity if you allow it. But I would recommend that you allow it for somebody who's earned it. I know I get a lot of inquiries from people saying, I want to be a remote coder, but I'm not seeing the jobs out there. Remote coding is tough because there are jobs out there. I know that Diversity Health has it. I know that Athena Healthcare is now offering it. But if it's within a physician practice, they sometimes, really, especially if it's a single physician, they need the bodies. And so it's not always an option unless it's a bigger organization. But if you have earned it, then it's something that I think a practice should consider. And you can only earn it by reflecting not only your productivity, but that you are a pleasant employee, that you're somebody that respects your job and the people around you. And it's only so that you can have maybe 1 week or 1 day, I should say, of quiet time so that you can catch up on some of your work. But the biggest thing is make sure that you are someone who can work independently. Being a remote coder, as you saw in one of my podcasts I had recently or heard about it, it doesn't mean that, okay, I can spend half the day doing my house chores, meaning that I've got loads of laundry to do. I want to change the sheets. I want to, clean this. I need to do this. I need to run to the store. I need to go to Target. I need to do all my errands. That's not what a remote coder is allowed to do. Basically, you're just being away from the office remotely, but you still have to sign in. You still have to access the information remotely. You still have to treat your remote position as a job. And so that's something that could minimize the drama and the noise and the distractions that come with working with an office. Maybe offer it once a week. You'd really be able to attract some really good employees if it was something that you eased into and did offer at least once a week to, again, independent, responsible coders, billers, people that are okay with working independently. And number 10, a diagnostic code that does not meet medical necessity for the CPT code that it's assigned to. So it's a problem if the provider's documentation does not support the link between the CPT and the ICD-10 code. In this case, the coder will have to go back to the provider for more information. And again, now we're back to the physician query and hoping we get that in a timely manner. So you have to have a clinical indication for the test. There has to be at least a chief complaint. Otherwise, there's no reason for it. Or if it is something that you do on a 6-month basis, is it because the patient has a status of a chronic condition that has you concerned, or are they under surveillance? There has to be a reason for it, not just because the physician wants it. Or because the patient saw it on TV and said, yeah, I think I'll get that. Unless they want to pay cash for it, then it's something that it doesn't matter if the insurance company is going to pay for it or not. But you still should keep in mind that even if you order a test or, anything like that, you're going to have to be able to support it with a reason on why you're ordering it. One thing I wanted to bring up, and that was our top 10 pet peeves before I bring it up. But in my episode, not the last one, but the one before where I was dealing with place of service issues, I inadvertently I have a correction. I had said place of service inpatient 25 on accident, and it was actually 21. I don't know if any of you caught that, but what I was doing is I was talking about place of service and I was going in order. So I was saying 22 is outpatient, and then I was going 23 is ER, 24, and I kept, for ASC, and I immediately just said 25 and it should have been 21. So I apologize for that in advance. Consider this the page 6 correction for that. Okay, so my personal tidbit this week, and it's kind of funny. Hopefully you'll find it funny. So one of the things that I really like, sort of, okay, so does that even make sense? I really like it, sort of, kind of a misnomer there. I guess I like going out with my friends for sushi, okay, but I don't like raw fish. So you're saying, okay, well then Terry, what are you doing? Well, I'm kind of a pretend sushi eater. So, and I also hate seaweed. I hate seaweed. I mean, with a passion. It'd be like telling me, no, you love Brussels sprouts. I don't. I don't care how you cook them. I don't care for those of you on the podcast that are listening right now saying, oh, well, you haven't had them the way I cook them. I have. Trust me. Brussels sprouts are evil. They're not good. Same with seaweed. I just don't like it. But I love going to sushi, and you're in Southern California, you better like going. So what I've learned is that you can create your own sushi. So what I do is I'll get I actually, I like to label everything that it's mine. So it's like Terry's California roll. I know, kind of a little self-serving. What can I say? But I ask them not to use seaweed, but to use cucumber. So they actually will slice a cucumber on the outside of the skin really thinly, and then they will roll up. Now I do like the crab, so it's kind of like a crab salad. So we do crab, jalapeno, avocado, another couple of little sticks of cucumber. They did put rice in there. I have one place that we go to that puts red bell pepper, little sticks in there, just tiny ones, and green onion. And there we go. They call it a lollipop sushi, and they put little sticks in it, and it's perfect. And everybody thinks I'm eating sushi like they are. And it's a definitely play on textures. It's very crunchy, but also has the middle. And then they put some sesame seeds on it too. It's awesome. So if anybody is thinking they want to go to sushi, but they don't know what to do, order Terry Sushi. Just try it. And it's really, really good. And I promise you, everybody will eat yours instead of theirs. So I'm just letting you know that in advance. So I hope now that we're at the end of March, everybody's getting out of the colder weather. We've actually had some beautiful days here in Southern California. I was able to sit outside. I actually can say I got a little sun, got sunburned a little bit. And then 2 days later we had rain. So what can you do? But it's getting beautiful. I'm excited for my 2-day gastro seminar coming up on April 9th and 10th up in Napa. So again, look at my website if anybody wants to come to wine country and hear about gastro coding. And again, take a look at our second quarter schedule at terryfletcher.net. So everyone, make it a great day, make it a great week, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at terrycoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.